Bueno, buenos días a todos. Muchísimas gracias por su asistencia. Es un gusto que estén con nosotros hoy en el Estado del Arte, que es una reunión que organiza la jefatura de nuestro departamento en cabeza del doctor Darío Echeverry. Yo voy a estar moderando la sesión y va a estar conmigo también el doctor Juan Pablo Umaña, quien es el jefe de nuestra división de cirugía cardiovascular, pero tuvo un inconveniente de último momento y se va a estar uniendo un poco más tarde. De todas maneras, muchísimas gracias. De todas maneras, les recuerdo que vamos a hablar del papel de la hibernación en el manejo de pacientes con cardiopatía isquémica. Y recordamos que al conectarse a esta conferencia, ustedes autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual pueden consultar en nuestra página web www.lacardio.org. De igual forma, les informamos que esta conferencia está siendo grabada. Hoy tenemos el gusto de presentar a 3 speakers que son ampliamente conocidos en el mundo entero realmente. La primera de esas speakers es la doctora Sharmila Dorbala. Sharmila, thank you and good morning. Thanks so much for being with us. She's the director of nuclear cardiology at the Brigham and Women's Hospital, professor of radiology at Harvard Medical School, and the past president of the American Society of Nuclear Cardiology. And she will be talking to us about the utility of PET in patients with ischemic cardiomyopathy. Esta conferencia va a ser seguida de la del doctor Mario García. Mario he's the chief of the division of cardiology, a professor of the departments of medicine and radiology, and co-director of the Montefiore Einstein Center for Heart and Vascular Care. He's also a mentor of mine and a good friend. So I'm extremely pleased, Mario, that you're with us. We have definitely 2 KOLs and global leaders of cardiac imaging. And last but not least, definitely, Mike, we have as a surgeon, as a cardiac surgeon, and which is absolutely key in the management of this patient, Dr. Michael Tong. He's the director of cardiac transplantation and mechanical circulatory support and cardiac surgeon of the Cleveland Clinic Foundation in Cleveland, Ohio. And he's going to be talking to us when, how, and when to check for viability before CABG in patients with ischemic cardiomyopathy. Thank you to all for being here. Thank you for joining us. And we're going to get started with Sharmila. Sharmila, the podium is yours, and you haven't been in Bogota yet. Mario and Mike have, and we hope to solve that very soon. In the meantime, the podium is yours, and thank you so much for being with us.
Thank you so much, Hector. Can you see my screen?
Perfectly.
All right. Good morning, everyone. Really delighted and honored to be here to present about the utility of PET in the assessment of hibernation in patients with ischemic cardiomyopathy. So let me start off with the case. So these are images of an 86-year-old man with days to weeks of shortness of breath and chest pain. He has multiple risk factors. He's on Lasix for adequate diuresis. And then you also will notice that he's had a recent inferior wall myocardial infarction with a troponin that was still elevated at this presentation with a very high NT-proBNP and elevated creatinine and eGFR of 51. So we started off with a REST N13 ammonia perfusion study, and here you can see a very dilated hypokinetic ventricle with regional, almost akinesis in the LAD territory. So what do you do next? Given his history of recent myocardial infarction, we went straight ahead to an FDG scan. And here you see the FDG studies showing a mismatch. So regions that are hypoperfused show intense FDG uptake. All the territories wherever there is reduced blood flow, there's increased metabolic activity with a lot of glucose uptake, suggesting that these cells are all alive. They're hypoperfused, but they're alive and they're still using glucose. So this suggests that this patient is likely to respond to revascularization. So this was his coronary angiogram. You can see a very complex anatomy, occluded right coronary artery, very tight lesion, even in the left main, but LAD with left to right collaterals. And they could only revascularize the right coronary in this case. So the right coronary artery fixed, and you can see beautiful flow in the right coronary artery, multiple stents were used, and that is all that could be done. Now here I can show you his ejection fraction. It's improved significantly from the 19-20% that you've seen on FDG to 40% after revascularization of the right coronary artery. So this is what we would like to see in these cases when there is an area of hibernating myocardium with LV systolic dysfunction. You revascularize the patient with the goal that that would improve patient's ejection fraction. Now, contrast that with this case, a 51-year-old, much younger patient, out of hospital cardiac arrest, severe multivessel coronary disease, which was not amenable to percutaneous intervention, came in with ventricular tachycardia. So here you see the perfusion images, stress on the top row, rest on the middle row, and FTG in the bottom row. And what you can see here is, again, large regions of perfusion abnormalities involving the entire septum, inferior wall, and infralateral wall. When you look at the rest perfusion images, there's significant amount of reversibility, suggesting that this patient has a large territory of ischemia in the right coronary and posterolateral coronary artery territory distribution, and probably even in the LAD that you can see here. FTG images, as expected, show mismatch with a lot of glucose uptake in the territories that were ischemic on the scan. So this patient, the interpretation was completely viable myocardium, ischemia plus hibernating myocardium, and given his young age, even though he had out-of-hospital cardiac arrest with prolonged resuscitation, he underwent bypass surgery and unfortunately did not survive, and he died of multi-organ failure. So again, these two cases illustrate the fact that even when you identify hibernating myocardium, there may be other factors that we need to consider in making a decision about coronary revascularization in these high-risk patients. So what are the other factors that you should be looking at? Patient's risk for surgery, absence of viability, baseline ejection fraction, the magnitude of scar, the degree of left ventricular remodeling, the timing to revascularization, which is from the time to diagnosis of hibernation to the time to revascularization. And of course, finally, as you may hear from Dr. Tong, suitability of the vessels for coronary revascularization. So if the vessels are not adequate, then the benefit from revascularization may not be as high. So what did we do in this? What do we do? So the goals of viability imaging are primarily to not just identify the viable myocardium, but therefore also identify patients who are likely to benefit from high-risk revascularization, taking into account the imaging or viability assessment findings, plus patient-related factors and factors related to surgical risk as well. So here's an example of a young patient who presented to us, referred to us because of LV dysfunction, and the question was viability assessment. So this is a rest rubidium 82 perfusion study with completely normal perfusion. But look at the ejection fraction. It's definitely reduced globally with an EF of 23%. So what would you do next? Would you go ahead with an FDG PET for viability? Would you do a thallium? Would you do low-dose dobutamine to look for inotropic contractile reserve? Or would you stress this patient? So remember, with radionuclide tracers, what you see as perfusion is retention of the radiotracer by the cardiomyocytes, which already tells us that the cells are alive. So viability is no longer a question at this point, but he does have systolic ventricular dysfunction. And the question is there stress-induced ischemia, which may be accounting for what we would call stunning? So this is the dobutamine rubidium study. Patient consumed coffee on that day, and you can see severe ischemia in the LAD territory. And this patient went on to have angiography, which confirmed it. So remember that important to look for stress-induced predictor of improvement in contractile function after revascularization. So what is viable myocardium? So it's hibernating myocardium is myocardium that's dysfunctional, recover function after revascularization program. Functionally, there's an improvement in contractile function with reperfusion or with use of low-dose dobutamine, inotropic contractile reserve. So what's happening at the myocyte level? The first change in hibernating myocardium is an abnormality in perfusion. This leads to metabolic changes, which eventually lead to contractile dysfunction. Therefore, when you're talking about hibernation, techniques that rely on imaging perfusion are going to be sensitive but less specific, whereas techniques that rely on contractile function are less sensitive but more specific in identifying this particular condition. So Dr. Mario García led this excellent review, which was published recently through the AHA in SERC-CV imaging. I recommend all of you to look at this. And here they published comparison of diagnostic accuracy of various imaging methods. Again, you can look at perfusion-based techniques having high sensitivity as well as late gadolinium enhancement, and looking at contractile reserve, dobutamine echo, dobutamine CMR, these techniques have higher specificity compared to perfusion-based techniques. So what are the metabolic pathways that are imaged by cardiac PET? So we can look at fatty acid metabolism. Because the mitochondria are very sensitive to oxygen deprivation, what you will see in hibernating cells is a preference to use glucose. And this basically FDG enters the cell along with glucose using the same receptors. Then FDG gets converted into FDG6-phosphate, which becomes trapped inside the myocyte, and that is what we are imaging. Ischemic cells overexpress these GLUT4 receptors on the cell surface. Therefore, ischemic cells are glucose avid. They use a lot more glucose than non-ischemic cells. When we look at patterns of perfusion and metabolism in patients, what you'll notice is blood flow is normal, glucose utilization is normal, function is normal, that's normal. If blood flow is reduced, as in the case that we saw, with a mismatch, increase in glucose utilization with decreased function, this is a hallmark of hibernating myocardium. If the blood flow is decreased, glucose uptake and function is decreased, this is SCAR. This is matched between perfusion and metabolic activity. The last pattern is what we would call stunning, where the blood flow is normal, but the perfusion, the glucose uptake may be slightly reduced and function is reduced. However, in this case, because the perfusion is normal, you would already diagnose it as viability. So what about the effect of myocardial scar on changing LV function after CABG? So this is the PAR-1 study, which showed that large scar is associated with small change in EF, small scar with greater change in EF. These investigators also looked at the added value of FDG PET in identifying outcomes. And basically, this is one of the few randomized studies where they looked at a large group of patients with low ejection fraction, less than 35%. And on post hoc analysis, the primary analysis showed no difference. Post hoc analysis, they showed that an FDG PET guided strategy was associated with better event-free survival compared to a standard strategy. Also, how much viability is necessary? Data from the Cleveland Clinic suggesting that about 10% or more, this amount of viability is important to identify benefit from revascularization. The PAR-2 study found a threshold of more than 6%, so 7% of more, and maybe the way they measured viability is different in the PAR-2 compared to the other studies, but usually a threshold of above 6-7% is likely to be associated with improved function. What about the stitch viability study? This is a large study of ischemic cardiomyopathy patients with low EF who were randomized to bypass surgery with medical therapy or just medical therapy alone. The primary study, as you know, did not show any difference initially, but on long-term follow-up with 10 years follow-up, they saw a benefit for bypass surgery in terms of outcomes. In the viability sub-study, which is not a randomized part of the study, what the investigators showed was that change in EF was higher in patients either on medical or bypass surgery, but the EF improved in patients with viability compared to patients without viability. Then recent data again also suggests that myocardial flow reserve can also be helpful in predicting benefit, suggesting that patients here with myocardial flow reserve less than 1.2 seem to have better outcomes with revascularization compared to those who have flow reserve more than 1.2. So to summarize, in patients with ischemic left ventricular dysfunction, viability imaging is not routinely necessary to make surgical management decisions, especially if patients have suitable anatomy for revascularization, they are reasonable surgical risk, they have angina and or evidence of ischemia on any tests, including ECG testing. In patients with challenging management decisions where the symptoms are unclear, it's dyspnea but not angina, they're very old, they have multiple comorbidities, increasing surgical risk, complex anatomy, or regional LV dysfunction, then these are the patients where further imaging with viability may be helpful to guide management. Thank you very much for your attention.
Dr. Dorbala, thank you so much for your presentation. Dr. Garcia, thank you so much for being with us today. You may start with your presentation.
Good morning, everyone. Can you see my slides?
Yes, we can.
First of all, thank you for the opportunity of joining this STEAM panel of experts here. It's a humble experience for me. And thank you, especially Hector, for putting this program together. I am very glad to have the opportunity of follow a speaker like Sharmila, who had really covered the most important aspects about hibernating myocardium, including the pathophysiology. And it almost seems like I predicted what she was going to say, since I won't be covering all the basics aspects. But I'm going to start with a case, a typical case that we find in our practice. Usually the most common scenario where we're asked to evaluate viability. This is a 48-year-old man, a former smoker with symptoms of heart failure, diabetic, hyperlipidemia, hypertension, peripheral vascular disease, who had already several interventions and basically has episodes of heart failure requiring multiple hospital admission. He has this MRI showing on the two-chamber view a partial scar in the posterior wall with hypocontractility. Another scar that we start to see in the high inferolateral wall and anterolateral wall. And when we look at the short axis images, on the left we have sequences for contractility. On the middle we see perfusion, and on the right we see late enhancement. We identified a large area of thin myocardium in the inferolateral wall, which a partial scar that involves about 25 to 50% of the wall thickness, and an ejection fraction that was somewhere around 30%. The coronary anatomy is shown here, and this is a patient who had a non-critical lesion in the LAD, but more importantly, a large circumflex, which is totally occluded. This is a CTO. And I think this is the most common clinical scenario, because if this patient were to have a critical lesion in the LAD, it would be unquestionable that this patient, without any further testing, would benefit from revascularization. But here the question is, do we need to engage to revascularize an occluded circumflex, either with bypass surgery or with a percutaneous approach? So CMR in ischemic cardiomyopathy has different roles. It can allow you to evaluate global left ventricular and regional left ventricular function. It definitely will help you with the assessment of viability in different ways. It can allow you to identify the presence of inotropic reserve, the extent of myocardium scar with gadolinium-based contrast agents, and the thickness of the myocardium at different regions in a way to predict the likelihood of recovery. In other scenarios, it can also help you differentiate if you do not have yet the coronary anatomy, ischemic from dilated cardiomyopathies. And even in the presence of patients who have coronary disease, it's often the fact that most patients with coronary disease is not the relevant feature, but rather a myopathic process. And finally, CMR plays a role in the evaluation of patients who are at risk of significant ventricular arrhythmias, both to identify prognosis, but also to guide ablation therapies. When it comes to the issue of left ventricular functional assessment, the MRI has the highest standard reproducibility for mass, volume, and ejection fraction. When you compare CMR with echocardiography, for example, the ability to detect small changes in left ventricular mass, small changes in left ventricular ejection fraction, or in ventricular volume is far superior to echocardiography or to any other non-invasive techniques. CMR can also be applied during pharmacological stress. Following the experience with stress echocardiography using dobutamine, CMR can follow the same protocols, in this case, with increasing doses to detect ischemia in somebody who has normal resting contractile function, or in the case of identifying viability using intermediate dose up to 20 micrograms per kilo per minute with very high specificities for the diagnosis of intact contractile reserve. When we look at in a meta-analysis that we performed a few years ago, low dose of dobutamine studies are important because of the high specificity. In other words, if you identify improvement in contractility in a segment that is akinetic or hypokinetic, and the patient has a revascularizable anatomy, it is very likely that this patient will recover function following revascularization. The opposite may not be necessarily the truth. The absence of contractility not necessarily exclude the ability to experience improvement and benefit from revascularization. This is an important fact to consider. But what it makes MRI different than echocardiography is the ability to characterize tissue. And in MR, we use different approaches that we call sequences that look at the longitudinal magnetization and T2 relaxation of different tissues. And by that, we can characterize the myocardium. If in addition, we add a gadolinium-based contrast agent, which shortens the T1 time, we can identify areas of normal or abnormal perfusion. But if repeat images following the injection, usually 5 minutes later, we identify the presence of increased extracellular space or the presence of a ruptured myocardial membrane, where gadolinium will go gradually and stay in longer, leaving these regions that appear with a strong signal at the time of nulling. And this is a very, very important study now published 20 years ago that look at the percentage of involvement of the wall thickness with the gadolinium late enhancement. When we see that there is more than 50% of the myocardial wall thickness involved, the likelihood of recovery is very small, less than 20%. On the other hand, when we see that there is less than 50% of the wall thickness involved, by scarring or by gadolinium enhancement, the likelihood of improvement in contractility after vascularization is significant. And that brings the other ability of MRI, now with contrast, to have a very high sensitivity to identify segments that will not improve with revascularization. In other words, if you have a transmural scar or a scar that takes more than 50% of the myocardial wall thickness, the likelihood of improvement in functional recovery of contractility is very low. Wall thickness can be measured very accurately with MRI, more accurately with any other technique. Initial studies suggested that segments that are very thin are unlikely to recover, again, with a very high positive predictive value to identify a scar myocardium. Subsequently, this study that was published in 2013 looked at a small cohort of patients who had wall thickness that was impaired, less than 6 millimeters. And I'm looking at a very small cohort out of 1,000 patients that underwent CMR for assessment of viability. There were about 72 that underwent revascularization who had thin myocardium. So this is a very small group of patients to take into consideration. And what they notice here is that if these segments had extensive scarring, more than 50% of the myocardium, the likelihood of revascularization was also very, very low. But if they had a scarring that was less than 50%, and this was also a very small number of patients, less than 20% of this group, the likelihood of recovery was higher. When you look here at the spread of the data, you can see that those patients that recover are usually at least with a wall thickness of 4 millimeters or more. So very, very thin scars, the likelihood is very low. And again, the likelihood of recovery depends on the percentage of transmurality. So the thinner the scar, the more likelihood that the wall thickening will improve following revascularization, with a significant improvement in, again, a very small number of patients. When we look at CMR to distinguish ischemic from non-ischemic cardiomyopathy, we do this usually in patients with low likelihood or intermediate likelihood of coronary disease who presents with LV dysfunction and who do not have significant risk factors or classical symptoms of coronary disease. We notice very clearly that there are two distinct patterns that identify patients with ischemic heart disease compared to non-ischemic cardiomyopathies. The presence of a transmural scar or a subendocardial scar almost universally are associated with an ischemic cardiomyopathy, whether any other pattern is less likely in this condition. Another important role that MRI plays is the identifying of a substrate for ventricular arrhythmias. And when we look histologically at the anatomy of patients who develop ventricular arrhythmias and sudden cardiac death, there are usually islets of cells that are viable with a different conduction property than the normal myocardium, interspersed from areas of fibrosis in a way that a reentrant circuit can be generated. These areas could be seen in MRI as what we call the gray zone. These are areas where there's partial gadolinium uptake. So you can see here next to this dense scar, an area that appears gray, here highlighted in yellow. And when we have patients that undergo a stimulation for inducing ventricular tachycardia, they are more likely to have gray zone, a larger gray zone, compared to those that are non-inducible. And when you look at patients who have significant areas of gray zone, more than 50% of the volume of their scar, the likelihood of events is much higher than in patients who have a scar that is homogeneous, that is what I call completely mature. This is another study looking at a single cutoff of a volume of infragray zone of 17 grams. And you can see here clearly that when that number is exceeded, the number of sudden cardiac death and appropriate ICD discharges increases in this patient population. In this meta-analysis, looking at gadolinium enhancement for prediction of ventricular arrhythmia events, both the presence of a scar, but more importantly, the presence of a gray zone was associated with a 6-fold increase in the incidence of significant arrhythmias or appropriate ICD discharges. And this is very relevant because, as you know, today, when we identify patients who require an AICD for ischemic cardiomyopathy, we rely almost exclusively on an ejection fraction cutoff of 35%. If we implant defibrillators in patients that have an EF less than 35%, only about 5% of them will have an appropriate discharge per year. On the other hand, 80% of the episodes of sudden cardiac death occur in patients who have ejection fraction above 35%. So we're missing a lot of potential patients at risk of arrhythmias who do not meet guideline criteria for AICD implantation. Very, very important when you look at this other meta-analysis here, this ability to predict malignant ventricular arrhythmias exists equally in patients with a low EF, less than 30, or an EF more than 30%, with sensitivities between 92 and 78%. More importantly, with a negative likelihood ratio that is very low. So the absence of enhancement of gadolinium has an excellent predictive value to identify patients who will not experience a malignant arrhythmia in ischemic and in non-ischemic cardiomyopathies. Now, we did this work a few years ago when we used another technique, tissue tracking, to quantify the contractility of the myocardium, in addition to the use of gadolinium to measure a scar. And we actually combine both of them. If there is preservation of contractility and a low volume of a scar, the likelihood of adverse event is very low. If you have patients with a large scar and abnormal contractility, the likelihood of event and death are very high. And when you see here, patients that have large delay enhancement but preserve contractility, the likelihood is intermediate, or when they have abnormal contractility but a low burden of gadolinium enhancement. So combining these two techniques give you a further refinement to identify patients at risk. This study using, in this case, only tissue tracking, not lead enhancement, also predict higher volume of MACE event in patients that have a low ejection fraction and an abnormal tissue tracking pattern, in this case, measuring global longitudinal strain compared to other groups. Now, where is the future of CMR in this area? We have now very accurate T1 and T2 mapping techniques that allow us to quantify the amount of edema and inflammation in the myocardium. These techniques, we usually use a very sensitive T2 sensitive T1 mapping technique, which is MOLI, which allows to identify areas of edema. And when you look here at different clinical scenario, this is actually very good in the setting of acute cell death, but also in the presence of a scar or in inflammation where the T1 signal is increased. In this study published in 2018, in a large group of patients with an acute coronary syndrome before this event, significant coronary disease that was included, and who had no contraindications for CMR. What they found is that the presence of an abnormal T1 mapping was associated with poor events, not only on the patients with low ejection fraction, but more importantly, in patients with preserved ejection fraction. In fact, the predictive value of an abnormal T1 mapping was greater in the patients with better LV function than in those with worse LV function. So the theory here is that in the management of coronary disease, when you are at the spectrum of low EF and a dilated ventricle, the ejection fraction and the burden of a scar measured by gadolinium determine outcome better when you're dealing with better ventricles, smaller LV cavities, better LV function, the T1 properties that measure inflammation, cardiac plasticity, the earlier process of atherosclerosis dominates the outcome. As of today, what we want is a technique that is highly sensitive and highly specific. In other words, having a high negative predictive value and a high positive predictive value. And I would claim that CMR can function very well in both of these areas if you combine gadolinium enhancement that give you a very good negative predictive value, not a great positive predictive value, but if you do dobutamine CMR to determine the presence of contractility, then you also can look at a positive predictive value. So in a different way, how Sharmila presented an algorithm, I would claim that the process of dealing with a patient without hibernation obviously requires that we identify a patient with left ventricular dysfunction, impaired ejection fraction, of course, and that the first step that we have to follow is evaluation of the coronary anatomy. If the coronary anatomy is not suitable for revascularization, it's almost not helpful to identify viability in this setting. If the angiogram show diffuse or no coronary disease, we proceed with medical therapy. Otherwise, if there are good targets, we then look for the presence of symptoms. If the patient has symptoms, it's not quite unquestionable that they benefit from revascularization. If they don't have symptoms of ischemia or the symptoms are atypical, we proceed with ischemia testing. And this is important when we look at some of the controversy about the use of hibernation for predicting outcomes, is that you really need to identify those patients that have an ischemic workup performed. If there is ischemia, and this is more than 30%, revascularization is indicated. Otherwise, is when we proceed finally with an evaluation of viability. And if you use CMR and you identify scar more than 50% of the wall thickness, medical therapy is indicated. Otherwise, if there's more than 20% of segments that have limited amount of scar burden, that indicates viability, and revascularization is the optimal management. Thank you very much for allowing me to participate in this conference, and I'm looking forward to Dr. Tong's presentation following.
Thank you, Mario. Thank you. I apologize. I was unstable. My connection was unstable after Sharmila talked, but thank you both, Mario and Sharmila, for outstanding talks. And we will finish with Mike. Mike, go ahead. Thank you, and the podium is yours.
Okay, great. Thank you very much. It is such a delight to be here. Thank you, Hector, for the kind invitation. And I really enjoyed listening to Sharmila and Marion. I've certainly learned a lot too as I listened to our panelists. So now, as a surgeon, our role is to amalgamate all the knowledge and all the information that our cardiologists and our cardiac imagers are able to give us and decide whether or not a patient is suitable for surgery. So what I'll do in my talk is I'm going to talk about how we systematically assess whether or not a patient with ischemic cardiomyopathy is suitable for surgery, I'll talk a little bit about the viability. I'll skim over that since Mario and Sharmila has already talked extensively about it, talk about some of the surgical considerations intraoperatively as well as the case. So at Cleveland Clinic, the foundation of our work has always been on the teamwork and our teams coming together. And this was demonstrated very early on between Mason Soames and Rene Favellaro. And as you know, Rene Favellaro was a steam surgeon for Argentina who came to Cleveland Clinic. And back in the 1960s, as Mason Soames was proceeding and performed coronary angiogram, Dr. Favellaro performed a coronary artery bypass in a large series of patients. Although he was not the first to do a coronary bypass, this was the first large series to demonstrate that coronary bypass is beneficial for these patients. In 3 years, he had performed CABG on 300 patients, and they had an angiographic follow-up with an 86% patency rate and a mortality rate of around 5%, which was just incredible, given that this was over 50 years ago. Since then, in the 1980s, we knew from the VA Corp study that patients with cardiomyopathy, ischemic cardiomyopathy with abnormal LV have the most to gain from coronary revascularization compared to medical treatment. And the STITCH trial at 10 years was following the STITCH trial, 10 years of follow-up. This is a study looking at patients with ischemic cardiomyopathy. And this is comparing CABG versus medical treatment for these patients. It showed that in the as treated group, patient who underwent the CABG had a 21% reduction in mortality with CABG compared to medical treatment at 10 years. So we know that patients with ischemic cardiomyopathy will do well with surgery and have the most to benefit, but yet there is still a hesitancy to operate on these patients with low EF. And that's mainly because of the higher risk of post-cardiotomy shock and a higher risk of morbidity and mortality associated with these patients. However, with a systematic workup that I will show you how our operative techniques, as well as backup with the temporary mechanical support, these are not patients that we have to fear. Rather, these are the patients that we should truly embrace as surgeons and as interventional cardiologists, because these are the patients that we can make the largest difference in their life in both survival and quality of life. So this is one such patient. This is a 47-year-old with typical risk factors, presents in CHF, and this is his coronary angiogram. You can see that the LAD is 100% occluded, the RCA is also occluded, and there's significant disease in the circumflex with two suitable targets. This is the preoperative echocardiography. You can see that the F is about 15%. The RV is moderate and there's moderate much regurgitation. So in a patient like this, how should we proceed? Should we proceed with a CABG? Should we proceed with a PCI, just medical treatment, or should we proceed with a transplant or an LVAD? Well, as we assess these patients, these are some of the things that I am looking at, and as these are some of the things that I'm considering to get a full appreciation of the overall risk for these patients. The most important thing is to look at the coronary targets and the quality of the coronary targets. We'll also do myocardial ischemia and viability, assess the degree of cardiac compensation or decompensation, and the presence of ischemic much regurgitation and LV dilatation and ventricular thickness, as well as the patient's overall condition, symptoms, and their comorbidities. So the coronary targets and the quality of the coronary targets is the most important thing when we look at to see if a patient is suitable for revascularization. On the left here, you have a patient with nice targets who we can revascularize and get a good result versus somebody on the right. This is a patient that really doesn't have anything that we can revascularize and improve. When it comes to myocardial ischemia and viability, I'm not going to go too much in detail as our previous speakers already spoken about them, but in the progression of dysfunction for a myocardium is it goes from normal myocardium in the setting of severe CAD can become stunned, and repeated ischemia can then lead to hibernating myocardium before leading to myocardial scar. But importantly, up to the point where the patient has a hibernating myocardium, these ventricles still have potential to improve, versus once they become myocardial scar and have cell death, that ventricle or that segment of ventricle will no longer improve revascularization. So viability testing, you're looking at both the physiologic and the anatomic, and these are some of the studies that can be done. And the two that we use here are PET with FDG as well as MRI with gadolinium. Now, ideally, we do prefer MRI with gadolinium. However, this is not always practical in patients who are already inpatients and also patients who are in the ICU. And also if a patient has renal dysfunction, we do tend to shy away from the MRI because of the incidence of renal failure post gadolinium infusion, and we prefer to use PET in that setting. So in general, if I have a patient that I feel that the scar burden is no more than 40%, then I'll go ahead with vascularization. For example, if I have a patient that has 20% of the LAD in the LAD territory that already has a greater than 20% scar burden, and in the circumflex territory that has a 20% scar burden, if we have more than that of scar, then I won't. I tend to shy away from revascularization. But if somebody just has a mild to moderate burden of scar in the LAD and the CIRC, for example, then those patients we can still go ahead and do surgical revascularization. But more importantly than viability is the hemodynamic considerations for these patients. We will perform a right heart cath on almost all of these patients with ischemic cardiomyopathy and decide whether or not these patients are compensated and how well they'll tolerate surgery. And I'll show you some of our internal data after. So if a patient has a cardiac index on preoperative cath of greater than 2, I tend not to worry about those patients, and those patients usually will do just fine with surgery. It's important to do these pre-op and not intra-op, because under anesthesia, the cardiac index will often drop. And also, I tend to focus a lot on the patient's right ventricle. There's a lot of things that we can do intraoperatively to support the left heart. However, we don't have a lot of tools to support the right heart. And the right heart doesn't need to be perfect. It just has to be good enough. And one of the best predictors hemodynamically at looking at right ventricular function is something called the pulmonary artery pulsatility index. And compared to other hemodynamic parameters, this has the highest predictive value. Essentially, it's a simple calculation. You take the PA systolic minus the PA diastolic and you divide it by CVP. And anybody that has a PA pulsatility index of greater than 1.5, usually the RV is good enough that they shouldn't have a significant RV failure afterwards. Looking at the left ventricular size, this is a very important parameter. If I have a patient that LVs are already extremely dilated, more than 6.5 centimeters, and the wall is already thinned out, then that patient would not expect a good recovery. And usually those type of patients will go down the LVAD route, but not always. Versus patients who have a ventricular size of less than 6.5 centimeters, or they have relatively preserved ventricular thickness on imaging, those patients tend to do better and have a greater chance of improvement. The patient's functional status and comorbidities are equally important. On the left, you have a patient who's coming to see you in the clinic, or somebody who's on the step-down unit, who's walking on the floor. Even if that patient has a low EF, they are well compensated usually and should do just fine with surgery. Versus on the right, you have somebody in cardiogenic shock who may have just had an arrest, similar to Sharmila's second patient, who's on multiple support and drips. Those patients will obviously do a lot worse. So the patient's functional status is a very important determinant of whether or not somebody's a surgical candidate or not. And finally, symptoms. If somebody has angina, we know that they have a viable myocardium at risk, versus somebody who predominantly has shortness of breath. Usually it's a sign of more advanced heart failure. Now, at the time of surgery, we will optimize these patients prior to surgery. If I have somebody who, when I see them, if they are cold and clammy and they seem to be in shock, I'll often admit them to hospital, put in a swan, and optimize these patients, often with after low vasodilatation, to get these patients in a better state for surgery. When it comes to the surgery itself, we will perform it as an expeditious operation and move very quickly. We'll aim for complete revascularization, and myocardial protection in these patients are absolutely key. I use both antegrade and retrograde cardioplegia. Buckberg is the cardioplegia that I use. It's a blood cardioplegia, and I'll typically give a liter antegrade and 500 mils of retrograde for induction. And then at every 15 minutes and after every anastomosis, I'll give another 500 of cardioplegia, and followed by a hot shot prior to removing the clamp. Postoperatively, we're very aggressive in placing impellas in these patients if needed, and balloon pumps if these patients are in shock. And long-term, they're all on optimal goal-directed medical treatment. So one thing that we have been doing over the last 4 to 5 years is what we call an LVAD backup strategy. So patients who we feel are at a high risk of developing intraoperative cardiogenic shock, these patients will undergo an abbreviated heart failure, advanced heart failure workup for LVAD and transplantation, not necessarily with the intention of going down the LVAD route, but just so that we know what our options are so we can have an informed discussion with these patients. And then in the operating room, we will plan for a possible impella surgery. And prior to going on bypass, we'll expose the axillary artery and put a 10 millimeter graft onto the axillary artery. We then go ahead and perform the operation as we would normally. And when we come off of bypass, if these patients are in shock, they're on high levels of inotropic support, and they still have a low cardiac index, then we'll go ahead and place an impella right then and there. And having the axillary cut down already done and the graft already done saves us the time and decreases the threshold for us to place these devices in. And this has been extremely helpful. So the device, as you see here, is placed across the aortic valve. We have used the Impella 5.0 and now the Impella 5.5 for this indication. So if we look back at our patient, this is the coronary anatomy that I showed. The right heart cath showed that the patient had a PA pressures of 65/30 with a right atrial pressure of 11. Cardiac index was good, was at 2.2, but the wedge was quite high. So this is a patient who who should have a reasonable cardiac reserve and should do well with surgery. And the right heart function is, despite the fact that on the echo it didn't look all that good, hemodynamically suggests that this right heart is more is dysfunctional, mainly because of high pulmonary pressures, but should have good reserve to come off bypass. So this is a preoperative echo again, and we performed a PET scan on this patient, and the patient had in the LAD territory had a small scar in the LAD territory, and the rest of the myocardial mass is viable. And so we have confidence that this myocardium will come back. So then we go ahead with surgery, perform 4-vessel CABG. We placed an impella because the patient had relatively high inotropic usage afterwards. Patient was extubated on day 1, and the impella was removed shortly after that, and the patient was discharged home on post-op day 8. And at 8 weeks follow-up, you can see that his myocardium has recovered to an EF about 40%. So now, what is the impact of the viability testing on outcome? So this is still more of an art than sometimes in science, I feel. Sometimes we have patients who have whose viability testing shows good viability, but yet after revascularization, the myocardial function doesn't always improve as predicted, versus other patients who does not show promising viability, yet they have fairly sizable gains. So now when we look at the STITCH trial, this was one aspect of the STITCH trial. Although viability testing was not mandated, it did provide some information. In overall, patients that did have a viability compared to without viability did better and had decreased the mortality. This is regardless of if they get revascularized or if they have medical treatment. And overall, overall patients that had viability, the revascularization didn't necessarily show a benefit long-term versus those that did not have viability, the revascularization did show a benefit. So in fact, in the STITCH trial, the addition of a viability testing tend to seem to muddy the waters more than anything else. However, the viability in the STITCH trials was done with the debutemy stressed echo and SPECT, and it was a binary yes or no, and it wasn't the same degree of robustness and the same degree of information that we can get with MRI or PET scan today. So if we look at our experience with ischemic cardiomyopathy, this is something that we recently looked at. Over a course of 3 years, we performed about 238 cases with EF of less than 30%, with a mean EF of about 20%. The endpoint for this study was not only to look at their survival, but also look at whether or not we can predict whether these patients will have difficulty coming off bypass, and which essentially is defined as post-cardiotomy cardiogenic shock, or PCCS. And this is defined by the need for immediate postoperative ECMO or Impella, or having a vasoactive inotropic score greater than 25, which for an example, an 82-year-old, a vasoactive score 25 would be somebody who's on 8 of epi, 0.05 of vaso, 6 of epi, and 0.25 milrenone. So multiple drips at moderate to high doses. If you look at a cohort as a whole, the age was around 64 years old. EF was about 22-24%, and most of these patients had a history of myocardial infarction. We did our Impella backup plan in about 45% of those patients. So 45% of those patients, we had done the axillary cut down to be ready in case they came off in cardiogenic shock. And what's important was that the viability testing that we did and the degree of viability was not a predictor of whether or not these patients came off pump in shock or not. However, what was a predictor was these patients' preoperative wedge pressures. The higher the wedge, the higher the incidence of post-shock, as well as the preoperative cardiac index and the pulmonary artery pulsatility index. So in essence, if you have a patient that is decompensating with a high wedge, low cardiac index, and a bad RV, that patient is going to be in trouble coming off bypass, versus somebody that's well compensated. We really don't need to worry all that much. Now, if you look at the longitudinal progression of the ejection fraction, these patients' EF improved from about 22 to 24% up to about 38% by 2 to 3 years, by 1 to 2 years after surgery. So as I evaluate these patients and as I talk to these patients, I tell them, you know, we're not looking for perfection. You've had myocardial damage. There's some damage that we just cannot reverse. But what we're trying to do is make you better than where you came from. If you have a patient whose EF has gone from 22% up to 36%, their life is going to be completely changed. Their management is going to be completely different, and their symptomology is going to be completely different. So again, this patient population, we're not aiming for perfection. We're just aiming for better than what they are. And we're trying to salvage every myocardial cell that they have to get them to a better state. So in conclusion, as we assess these patients and consider for surgery, preoperatively, we're looking at the targets, we're looking at the viable LV mass, we're evaluating for RV function, the size of the ventricles, and the overall patient characteristics, and how good they look and how sick they are. Intraoperatively, we aim for complete revascularization, good myocardial protection, and optimal medical treatment postoperatively. And patients that we don't have these criteria and have that we think will have a poor chance of coming off bypass, we'll use the LVAD backup strategy. So back to the original question: when, why, and how do we check for viability prior to CABG and ischemic cardiomyopathy? So this is quite simple. We will do viability testing everybody whose EF is less than 30%. it's not necessarily a disqualifier for these patients for surgery, but we do feel that has some prognostic value, and it helps us inform us in terms of talking with the patients and getting informed consent. Although this does not predict post-cardiotomy shock, we think that this predicts EF improvement in each segment of the myocardium, and that this is something that we are currently looking at right now in those 238 patients, whether or not the viability in each myocardial territory, whether or not that predicts actual improvement following revascularization. And we favor PET and MRI for these studies. So our algorithm is really quite simple when it comes to deciding whether or not a patient should get operated on. Number one, will the patient survive surgery? If a patient has a good cardiac index going into surgery, I can go in and perform a sham operation and the patient will still live. So if a patient looks good, they're compensated, I don't worry about that patient versus a patient who has multi-organ failure in the ICU who is decompensated. That patient, I'll worry a lot more, and we'll try to optimize and support that patient, even put in a temporary mechanical support to get these patients to a better state before they can undergo surgery. Now, if a patient I feel is a good surgical candidate, do these patients have good enough targets where revascularization will help? And if yes, then we will go ahead with surgery. And then we look at the rest of the profile, their viability, to decide if they can just go ahead and get a CABG, or whether or not we need to do an impellant backup strategy. So this is our, it's quite simple. And really at the end of the day, it's sometimes the questions are complicated and the answers are simple, as Dr. Seuss has said. So we've published our guide on how we think about these patients, and this was published last month in Innovations. It's a paper that we've written on a CABG for failing heart, a how-to guide to using modern mechanical support as a backup. So with that, I'd like to thank you for your attention. And again, I am absolutely honored to be here, to be speaking to you, and I look forward to the discussion. Thank you again.
Thank you. Thank you, Michael. It was also an amazing talk, spectacular, just like Mario's and Sharmila's. And in the interest of time, we're going to get started with questions. The first question I have is for Mario particularly, and that is, in your very elegant meta-analysis, Mario, you mentioned that adding dobutamine would increase both specificity and positive predictive value. Now, there's a question in regards that, you know, what Ray Kim does with his patients at Duke, and he's not currently doing dobutamine. So what's your opinion on that? And also for Sharmila and for Mike, if you, obviously Sharmila probably will be doing PET as well and consider doing PET given the fact it's an excellent study for it, but would you add dobutamine to the protocol? So after what Mario found in his meta-analysis, increasing the positive predictive value and increasing the specificity, it would be a better test?
You know, let me tell you that even though I spoke about CMR, and that was the assignment, we do use PET quite often here. Sharmila knows our program. Mark Craving runs our PET program. We are fortunate to have cyclotron agents here, and we do quantitative flow reserve. I do believe that PET is an excellent technique too. If you have a single shop, if you don't have the capability of having all imaging modalities at your hand, and you have one MRI system, the ability to do dobutamine will enhance your prediction of whether there will be improvement in contractility. Not necessarily will tell you that patients that don't have contractile reserve should not be operated, as Michael very clearly demonstrated, and stitch proof patients will still benefit from revascularization. But if you want to get an idea to whether contractility will improve, inotropic reserve is a more specific technique that we have available. And as Sharmila pointed out, you can have tissue that is viable, but the histology has changed. The sarcomeres are no longer there. You have cells that are metabolically active, but whether they are able to regenerate the actin and myosin filaments and contract in the way that they once did is variable from individual to individual. How long has been the period of hibernation? And remember, in this talk, we talk and we show examples of patients who had a recent ischemic event and others that have very chronic persisting LV dysfunction. There is a big spectrum between in ischemic LV dysfunction from the stoning that occurs after an acute ischemic event to the chronic process of repetitive ischemia.
Okay, I think Juan Pablo Umaña, who's our chief of heart surgery, he's moderating as well. Juan Pablo, go ahead, please. Thank you. Juan Pablo. Okay, it sounds like he had an issue. The second question I have for all of you guys is one thing that was mentioned by Sharmila, and you always have, PET and CMR and PET as competitors. And obviously, as Mario just pointed out, and as Sharmila very elegantly showed us, it's an outstanding technique. There is a benefit in those patients who have end-stage renal disease or chronic renal disease as well. And in the US, when I was practicing there, there was no way you would give like a cc of gadolinium to those patients after all the NSF issues that had happened. And in England, the practice is very different. With Gatovist and with linear agents is completely different. Are you guys in the US, in Boston, New York, or Cleveland, are using gadolinium, particularly Gatovist, gadobutrol in these patients? Or if a patient has renal disease, is given a safety profile and very strict, regulation, you just go to PET immediately?
I can respond first if you like on this. So we will use it only if there's no other imaging technique that will answer the question, right? If there's an alternate test that could be used, for example, for viability for PET, we would go with PET. So Mario actually beautifully illustrated, like at centers that have access to high quality MR and PET, the decision is really patient-centric. There's no algorithm, we say PET first or MR first. There are many cases where we start with MR first because it's a heart failure question, and MRI provides so much information in a patient with heart failure. And then we may proceed with PET in other cases, right? For sarcoidosis and other things. So basically, I think if you have access to both high quality, answer simple. You do a patient-centric approach. Look, if your question is looking for scar, we would go with MRI. If the question is looking for hibernation, we would go with PET in a simplistic terms. But the bigger challenge is, what about sites that don't have access to PET or MR? I think that is a bigger challenge because we know that dobutamine echo, is specific, but sensitivity is limited. So I think that is where the challenge is in terms of practice rather than sites that have both high quality techniques.
Okay, in Cleveland, historically, we've not used MRI with gadolinium patients with renal failure. That's changing a little bit. And recently, I have noticed a few patients with renal failure getting gadolinium, and maybe they've adopted the UK approach, and it may not be as big of a concern as we originally thought. But as Sharmila mentioned, we do have access to both. So whenever I have a patient with renal dysfunction, I just go ahead and get a PET because I feel that the information I'm getting from it is equally valuable. And most of the time it's the viability is only one aspect of what I'm deciding, and often we'll have already decided whether or not this patient is going to surgery or not based on the targets.
Outstanding. Michael, it's great to see you again.
Yeah, great seeing you, Juan Pablo.
I'm sorry, I was having old people problems. I just couldn't make my technology work. Thank you very much for these excellent presentations, guys. I have a couple of questions from the audience. One from one of our young interventional cardiologists. He mentions a recent study from Bangalore showing equivalent results between CABG and PCI in these patients. Michael, what's your take on it? What's Cleveland Clinic's approach to this? Should we be thinking about surgical revascularization only, or does PCI have a role or play a role in these patients?
Yeah, that's a great question. So, when we evaluate patients, we're thinking lifelong outcomes. We're not thinking 30-day survival or 1-year survival or 3-year survival. We want to give these patients a strategy that can last them 20, 30, 40 years. And that's going to be a combination of coronary revascularization, LVAD, transplant. And the reason we don't like to go to LVAD or transplant right away is, if we can get them another 5 to 8 years or 10 years or longer with coronary revascularization before needing that is definitely the way to go. So if you look at the STITCH trial, even those patients that did not have an improvement in ejection fraction afterwards, they still did better with CABG compared to medical management. And it's mainly because the fact that you are protecting the remaining myocardium that's still viable, and you're preventing future MIs. So it's the same arguments of CABG over PCI over time. Yes, in the short run, your outcomes will likely be similar, but in the long run, you're not just protecting the lesion question, but you are also protecting the patient against future new lesions. And for a long-term benefit for these patients, there's no doubt in my mind that CABG is better. And that's why CABG in our center is the go-to approach for these patients. Now, not to say that there's no role for PCI, but we reserve PCI in these patients where we truly feel that these patients likely will not have a long-term benefit of CABG over PCI, for example, if they're 85 years old, or they have multiple comorbidities, or they're just not a good surgical candidate. And so a PCI will be reserved as a backup. But the primary approach that we have is CABG, mainly because we feel that will give the patient the best long-term outcome. Because, these patients don't necessarily have much myocardium left to lose. Going from 55 to 40%, you're going to be fine, but going from 35% down to 20% is a much different scenario. So we want to try to protect as much as we can.
All right, excellent. Now, and another question from the audience is there a role for stem cell or stem cells? Are stem cells still in the mix? Should we continue to think about that? Is that something that has been discarded, or do you guys think there is a role for stem cell transplant or implant or injection into those areas of injured myocardium?
Yeah, historically, if you look at the stem cell trials, they have not been effective in improving the ejection fraction, and mainly because the stem cells just don't stay in the myocardium. In the previous studies, within 30 minutes, most of the stem cells that you injected are completely gone, and just doesn't stay. Now, Todd Rosengart in Texas is doing a study with a different approach. And that does tend to cause the stem cells to stick a little more, and we're part of that trial. But that's right now only in patients who have non-revascularizable myocardium, but patients are still symptomatic. And so, I think stem cell currently, with the technology that's already there, hasn't shown to be beneficial. However, not to say that this will not be something that's viable in the future, just we still haven't figured out a way to get these myocardium to come back in patients who've already had scar.
Great.
I have a question that is coming on from our CCU director. I'm going to frame it in a different way. If you guys, Sharmila, Mario, and Mike, would have $1 billion and redo the stitch trial, how would you do that? I guess you would be using PET and CMR, but because recruitment was a pain in the neck, and when you talk to Bob Bono and to Eric Velasquez, I specifically asked them a question when they were here, and they both said that the trial almost was aborted because of all the difficulties. If you would have that amount of money, what would be the design of the new Mario, Sharmila, and Mike's stitch trial in the 2020s?
Yeah, that's a great question. I think nowadays you almost no longer have equipoise between vascularization and medical management. I think we now know that patients with ischemic cardiomyopathy, it's clear that revascularization in these patients is better. So I don't think you have the same equipoise as you had back then. The mortality now in the group of patients that I showed you in the last 3 years, the mortality is 1.5% in that whole cohort of patients with a mean EF of 22%. I mean, that is a very high barrier for any other treatment to achieve. And if we can offer a surgery with that high upside, with a low mortality like this, with our temporary devices that have available to us, it's, I mean, if I was that patient, I definitely want to get revascularized to have the potential benefit from it. It'd be very different if my mortality was 5%. So, I don't think that you have the same degree of equipoise as you had back then. And I'm not really answering your question, but, I think that these patients should get revascularized.
I do have an opinion. I think if you were to do it, the most important thing in my mind would be that the imaging data should be completely blinded, kept blinded, and do a post-hoc analysis, because I think that invariably, once you do imaging, there is an inherent bias for selection and for change in management plans. And that can influence the outcome. So I think, these patients should be decided whether they have the anatomy that is suitable or not, be already planned for revascularization, and the imaging be done, but not used for clinical guidance.
Yeah, I agree. I think that's an really excellent question, Hector, and I fully agree with Michael and Mario that what may end up at this stage for this question is a pragmatic clinical trial. I think randomization is going to be really challenging, but maybe using a pragmatic clinical trial approach, using more advanced techniques for viability. And Michael really illustrated beautifully in his talk, and I learned a lot actually from his talk and from Mario's talk about the real technique of how we could use these advanced imaging techniques to manage patients in real life. I think a pragmatic study is what may be the approach.
Well, this has been absolutely an absolutely fascinating start of the day, and we could stay here for hours, but unfortunately, everybody assisting and Hector and I have to. As well as you guys, we all have to go work. So we'd like to thank you very much for your talks, for your interest, for your generosity of knowledge, and sharing all this with our community of cardiovascular physicians. It's been a pleasure seeing you all again, although I was muted for most of the session. Hector?
No, I can't agree more. Thank you, Sharmila. Thank you, Mario. And thank you, Mike. We are extremely honored to have you as our speakers this morning. And hopefully we can have maybe, why not, Viability, meaning in here in Bogota, and we can take advantage of that and have Sharmila come all the way down and have Mario and Mike visit us for a second round or third round. Thank you all. Thank you to our audience, and we hope you all have a good rest of the day.
Thank you. Have a great day.
Bye.
Thanks
Thank
very
you.
much, everybody.
Bye, everyone. Thank you.
Mike, have a good one.
Bye.